Idecabtagene vicleucel was FDA approved in 2021. Ide-cel was approved based on the registrational phase 2 KARMA clinical trial where 128 patients were treated. In this study, it was demonstrated that higher peak concentration of pro-inflammatory cytokines were associated with developing higher grade cytokine release syndrome. However, there have been no reports in terms of association of cytokines with response to Idecabtagene vicleucel. As we know, cytokines are master regulators of the tumor microenvironment as they represent the main communication bridge between cancer cells, tumor stroma, as well as the immune system. So the study objectives or the goal for our study was to assess the association of cytokines and the pre-CAR T bone marrow composition with toxicity and response in patients receiving ide-cel. This was a retrospective analysis of patients treated with commercial ide-cel at Moffitt Cancer Center and consented to a biospecimen protocol. We measured serum cytokines using an ELA immunoassay at apheresis, at day -6 pre-lymphodepletion, at CAR T infusion, and weekly thereafter. We also measured inflammatory markers like ferritin and CRP in a pre-CAR T bone marrow biopsy. In a subset of patients, we were able to perform flow cytometry on the bone marrow aspirate to immune cell phenotype, T cells, myeloid cells, and natural killer cells. Now, in our study, we had 86 patients who essentially participated or were enrolled. Our patients, nearly 1/3, had aggressive disease features like pentarefractory disease, high-risk cytogenetics. About 30% had high plasma cell burden, which was approximately 50% or more plasma cells in the core pre-CAR T bone marrow biopsy. Safety profile was similar as to what was seen in KARMA. We did have 3 patients that died by day 90 due to complications of myeloma progression. Response rates, at day 90, overall response 67%, complete response approximately 32%. In terms of cytokines in association with CRS, we identified that a higher peak concentration of pro-inflammatory cytokines associated with any grade CRS and a higher peak concentrations of interleukin-6, which is a key mediator of CRS, was associated with grade 2 or more cytokine release syndrome. In terms of cytokine associations with neurologic toxicity, we identified tumor necrosis factor alpha at a higher concentration at apheresis to be associated with ICANS, as well as interleukin-15 and angiopoietin 2-to-1 ratio, and higher peak concentrations of interleukin-6, 15, and angiopoietin 2-to-1. With any grade neurologic toxicity, grade 2 or higher, it was higher peak interleukin-15, angiopoietin 2-to-1 ratio. As we know, interleukin-15 does regulate T cell effector function, and it may exacerbate neuroinflammation and cerebral edema. Angiopoietin 2-to-1 is a marker of endothelial dysfunction, which may lead to permeability of blood-brain barrier. Inflammatory markers, particularly baseline and peak ferritin, were associated with developing neurologic toxicities. We also looked at response and identified that a higher peak concentration of certain cytokines like interleukin-2, GM-CSF, TNF-alpha, interferon gamma are associated with achieving a partial response or better to ide-cel, as well as best response or better. And we looked at the association of cytokines with plasma cell burden and identified that in patients with high plasma cell burden, they have a higher concentration of certain cytokines. Last but not least, in a subset of our patients, we did perform flow cytometry, and we identified that in patients who have a high plasma cell burden, they express markers of T cell exhaustion and natural killer cell exhaustion, in particular, higher expression of CD39 among CD4 and CD8 T cells, and higher expression of T cell immunoglobulin with item domain among CD4 T cells, and higher expression of CD56 dim natural killer cells, which ultimately may lead to impaired activation, proliferation, and upregulation of immune inhibitory receptors that may lead or favor tumor immune tolerance. So in summary, a high plasma cell burden is associated with systemic inflammation, which in turn may lead to T cell dysfunction and impaired T cell fitness, and ultimately may impact CAR T product. So our study does show some association with cytokines and inflammatory markers and pre-CAR T bone marrow composition with toxicity and response, and hopefully provide some early insights into toxicity prevention and therapeutic optimization to improve efficacy and reduce relapse. Larger studies with a longer follow-up certainly are needed to understand and analyze the complex relationships of inflammation, immunity, toxicity, and efficacy. Thank you so much.